Hey everybody. So today we are going to discuss the lipid storage disorders and glycogen storage disorders. So what's more important to know is that how these things work, and they're not very important for step 2 and step 3, but you can get something close to 2 or 3 questions. So the whole goal is that these are easy to fetch marks. You should just know your thing. It's more like a revision. And so I'll start with glycogen storage, and then we shall take it forward. So glycogen storage disorder. The most important thing to know is that glycogen is like a tree. Okay, it has all the branches, and glucose is like twigs. Glycogen is like this. Okay, now each of this represents a glucose, and our glycogen keeps branching, and it goes on and on and on. Glucose, on the other hand, is just one. This is the one component of glucose, how I'm going to represent. And glycogen branches. Now, this glycogen stays in the liver. It is going to convert to glucose to maintain the blood glucose levels, so that when you sleep or when you starve, perhaps, let's talk about starve, the initial 15 to 18 hours, the glycogen always finds a way to cover up. After that, it's the different metabolism of lipids and some protein catabolism. And I'm going to just put the physiology here. It's not important to know the whole thing, but I would recommend that it would come handy when you try to correlate the terms. So please take a pen and paper and go along with me. So let's talk about a fed state, right? A person got fed, and the whole glucose is getting absorbed from the intestine. They ultimately go to the arteries to supply, but before that, they enter the portal system. So there's a lot of veins in the intestine, and the vein supplying, like the short gastric veins, and there are a lot of other veins supplying the stomach. They all drain into the portal system, and that's where the glucose has to pass through the liver. So the fed state, glucose. Now glucose is going to convert to glucose 6 phosphate, and glucose 6 phosphate is going to convert to glucose 1 phosphate. Now this conversion of glucose to glucose 6 phosphate is by hexokinase. The same thing goes for glycolysis, right? Glucose to glucose 6 phosphate. Now glucose 6 to glucose 1 phosphate occurs with an isomerase. Now the things are a little interesting. Is you have something called as a UDP glucose phosphorylase. This UDP glucose phosphorylase and followed by a glycogen synthase makes glycogen. It's simple as that. So what does this UDP glucose phosphorylase do? It makes a UDP glucose, and this UDP glucose is going to become a glycogen when there is something called as glycogen synthase, and it becomes glycogen, right? So that's it. That's the whole process of glycogen. Now let's talk about a state after fed, where the person is in, let's say, some kind of fasting mode due to sleeping. Simple. Let's talk very physiological. So person sleeping for 8 hours, right? And also it's not good to have food before sleeping. This person just had food, went to bed. So in the initial 3 4 hours, or maybe up to 5 hours, usually the 3 4 hours, we can see that the blood glucose is maintained by the food. After that, the glycogen should be broken to glucose. But one thing to be noted is this glycogen, what is formed is straight glycogen. That is something we call as alpha 1,6 bond. That is two glucose are bonded by alpha 1,6. okay, the first carbon and the sixth carbon of one and the other glucose. Now, to branch this, right, it's a property of glycogen. We have a branching enzyme, and that branching enzyme is going to make an alpha 1 comma 4. That is the carbon atom of this, followed by the carbon atom C4 of another glucose molecule, and it goes on. It keeps branching on and on. So you branch it however it is, right? So yeah, so this is what happens. Now there's a glycogen, and now the person is in fasting state, right? Now till now what I showed in the pathways fed state. Now in fasting state, what happens is the glycogen is now, it has become a very huge molecule. There's a lot of alpha 1 comma 6 and alpha 1 comma 4 bonds. It's like a huge tree and a lot of branching. To break this into small components, you should take one at a time, right? So they're going to break down into limit dextrin, which is again this big massive glycogen is broken into small components. So that's one component is called as limit dextrin or alpha limit dextrin. And limit dextrins are being broken by 4 alpha DGT. Okay, we'll talk about this enzyme. So 4 alpha DGT, okay, it is going to break them into a simple glucose molecule. Like, let's just say it's going to break them into something where we can just see an alpha 1 comma 6 and alpha 1 comma 4. And finally, this is broken in at the alpha 1 comma 6 bond, sorry, alpha 1 comma 6 alpha 1 comma 6 bond. At these bonds, we're going to break it. We're going to make it finally into glucose 6 phosphate. So there we go. We have a glucose 6 phosphate, and glucose 6 phosphate won't be released into the blood because the blood is looking for glucose. We have all our machines to measure in the form of glucose. So glucose 6 phosphate becomes glucose by using glucose 6 phosphatase. Now this phosphatase takes out the phosphate and convert to glucose. So finally we have glucose. It's going everywhere in the blood and it's maintaining the blood sugar. So this is the whole process that takes place. Now if someone asks what's the debranching enzyme, it's these two guys. You must always remember, it's always these two people. Let's just highlight them. There's 4 alpha DGT, as well as, I'm sorry, I should have put here again the debranching enzyme. Again, the one who breaks alpha 1 comma 6, that's also called debranching enzyme. Even this 4 alpha D-glucuronal transferase, this is also another debranching enzyme. So there are two debranching enzymes. If someone says debranching, it's always two enzymes. The enzymes which is 4 alpha DGT, and finally who's going to break alpha 1 comma 6 into glucose 6 phosphate. Very important to remember, it is still glucose 6 phosphate and not glucose. I'll tell you why. Because glucose 6 phosphatase deficiency is von Gierke disease, which we'll come to. So this is the whole pathway. You don't have to remember it, but you just kind of have to remember it for your exams. All right, so let's go with the diseases, right? So when it comes to diseases, people use a very common mnemonic, and this mnemonic is vice presidents can't accept money. So that's the mnemonic. I don't know who found it, but vice presidents can't accept money. VPCAM. Von Gierke, Pompey, Corey, Anderson, McArdle. These five guys. We'll speak one by one. So first, talking about one von Gierke disease. So about von Gierke, the deficiency. Where's the deficiency? Right. The deficiency is with these guys. is glucose 6 phosphatase. So glucose 6 phosphate cannot become glucose. So that's one GUX. So let's see what we can do over there. So what is the enzyme that's deficient? Glucose 6 phosphatase. Sometimes they'll ask you what's the enzyme, or they'll give a bunch of symptoms and you need to correlate with these diseases. So glucose 6 phosphatase is deficit. So ultimately the glucose, let's change the color, glucose 6 phosphate cannot become glucose because this enzyme is absent. So for these patients, what are the clinical features that we look for? There is a few. So first thing to note is that there's going to be a lot of amount of lactic acid. Okay, lactic acid is high. It's very important to remember lactic acid is going to be high. And the other factor is uric acid. Uric acid is also going to be high. So lactic acid is high, uric acid is going to be high, and increase triglycerides. So triglycerides are going to be high, and these two organs, that is liver and kidneys. So you'll remember it as hepatorenal, right? Hepatorenal. They have big liver, they have big kidneys. Why? Because if glycogen cannot be broken to glucose, because up to glucose 6 phosphate you can break, they're going to get accumulated at the storage organs, that is the liver. So ultimately it's going to get accumulated at all these places, and they're going to cause swelling of these organs. That is all you have to remember. So glucose 6 phosphatase deficiency is going to cause increased lactic acid, increased uric acid, increased triglycerides, and hepatorenal. So you just have to remember this, right? There are two acids, lactic acid, uric acid. There's going to be increased triglycerides. And finally, what we can see is there's hepatorenal. A lot of them will be like, why this increased triglycerides? Yeah, because the liver is messed up. Okay, so the triglycerides will go up. So that's what one should know. Now, what is the treatment for this? Now, how can you maintain the blood sugar for these patients? So what we do is, in the form of the treatment way, we would give them glucose. You can give them glucose, or you can also give cornstarch. Okay, these are the two things you can give, but avoid fructose and galactose. It's very important because fructose and galactose is not going to maintain the blood sugar. So avoid fructose, and the same thing goes for avoid galactose. Avoid fructose, galactose, give glucose as well as cornstarch. Now coming to POMPs. So POMPs is due to the enzyme that is going to break this. Oh, I guess I have not mentioned another pathway to burn. That is, what happens is this glycogen can directly become glucose. Okay, they can directly become glucose by a pathway that is called as lysosomal. This only occurs in the lysosomes. Okay, lysosomal alpha 1 comma 4 glucosidase. So this occurs in the lysosomes. Okay, just to remember, this is the only pathway occurring in lysosomes. So now we came to one GUX, right? One GUX we completed, and when it comes to POMPs, the enzyme that is this lysosomal alpha 1 comma 4 glucosidase is absent. So what's going to happen? Well, the fact about POMP is it has something to do with the heart. Okay, it's going to affect your heart, and that's kind of a concern for everybody, right? So for these people, it's always the muscles and the heart. Okay, pompy, something as pompous. So there's going to be a big heart, and there are going to be a lot of heart issues, muscle issues, right? So cardiomyopathy, cardiomyopathy. Remember it. It's going to have cardiomyopathy. You see, for these patients, they're going to have hypotonia. Hypotonia. Now, why hypotonia? because they are not able to make glucose. Now these two pathways important, and there's going to be muscle weakness. Okay, so hypotonia and enlarged tongue. Okay, so enlarged tongue is seen in hypothyroidism in infants. We can see the same enlarged tongue for Pompey's disease because lysosomal alpha 1, 4 glucosidase is deficit. Now this is Pompey's. Now there are other diseases, right? So you should remember this mnemonic when you go to Cody's and Anderson. So we'll talk about Cody's first. So it's this A, B, C, D, right? So Cody's is all about debranching enzyme. So in Cody's, the debranching enzyme is deficit, and in Anderson, okay, in Anderson, what we see that the branching enzyme is deficit. The one going to branch the glycogen, right? So let's talk about Cody's. Now we can go back and we can just see this, right? So Cody's is all about the debranching enzyme. That is these two fellows over here, right? These guys. These are the debranching enzymes. The one who breaks alpha 1, 6, okay, and the one who is involved in with this 4 alpha DGT. Now some of you will be like, what are these two enzymes? I want to know the full name. It's not important to remember. Nobody's going to ask you, but this 4 alpha D is actually 4 alpha D. Okay, gluconotransferase. Okay, that's what it is. So this D gluconotransferase. And what is this alpha 1, 6 debranching enzyme that breaks it? If we can call this as alpha 1, 4 glucosidase, I'm sure that we can call this enzyme, which works here, as alpha 1, 6 glucosidase. So these are the two enzymes. These are the two debranching enzymes that is getting involved. Okay, the 4 alpha DGT as well as alpha 1, 6 glucosidase. Now we'll come to that. So we're talking about Cody's, right? So Cody's, what you need to know is these are the two enzymes. 4 alpha D gluconotransferase. Now, I do understand it's very hard to remember because I have revised this more than, let's say, 20 to 30 times, and still I need to revise this the day before exam. So I keep this as a flashcard. But it's very important to remember them because you get 2-3 questions, and it's definitely an easy answer. So 4 alpha D gluconotransferase and alpha 1, 6 glucosidase. So these guys are deficit. And who are these guys? These guys are C with D, right? So that is, these are debranching enzymes. Now, what are the symptoms you look for? You will look symptoms just like von Gierke, okay? Just like von Gierke, you're going to see some kind of symptoms. But remember that the lactate is normal. So that if you see normal lactate, okay, and it's like mild symptoms of von Gierke, there's a big spectrum of von Gierke's disease. But if they have normal lactate, it's Cody's. So they may have uric acid high, they're going to have maybe triglycerides, they're going to have other muscle issues. Okay, all of them will have muscle issues, of course, but normal lactate. Okay, so usually they don't ask Cody's, but if the lactate is normal, you know it's not von Gierke's. So that is all you need to remember. And normal lactate can be Cody's if it has symptoms like von Gierke. What we are worried about von Gierke's is that is going to be severe hypoglycemia. Okay, but in Cody's you don't have severe hypoglycemia. You will have a little bit hypoglycemia here and there. Lactate is normal, well and good. So this is what you should remember of. Okay, it's a mild form of von Gierke. Von Gierke's disease is Cody's. So what happens because of these guys are not working, right? You'll see that in the cytosol where the glycogen becomes glucose, right? The metabolism, because you'll see an increase in the amount of alpha limited dextrins because they are not going to be further broken down. So this could be another clue. But this kid is not going to have any hypoglycemic episodes. So just remember that. Okay, and gluconeogenesis is always intact for this kid. So that is all you need to remember. It is just going to be very mild. There's going to be increased alpha limit dextrins. These things are very conceptual. I think if there's no enzyme, the product is going to be less, but the substance that makes the product is going to be accumulated, right? So substance is going to be more. There's no enzyme and the product is less. The same thing goes for this alpha limit dextrins. Now coming to Anderson. Now Anderson is due to the branching enzyme, right? So let's go all the way back. So where do we have the branching enzyme? Oh, there we go. So we have the branching enzyme here. So this branching enzyme is not there in Anderson, okay? And that is what we're going to find out. Now in Anderson, again, there's no branching enzyme. Branching enzyme is deficit. And what you see over here is there's going to be hepatosplenomegaly. Okay, hepatosplenomegaly. This stands for liver, this stands for spleen. So hepatosplenomegaly, and you do see hypoglycemia early in their childhood. Sorry, late in their childhood. So this is what is in Anderson. It occurs late. This hepatosplenomegaly symptom. Also remember, these kids are going to have a little bit of Pompe's also. That is hypotonia and cardiomyopathy. So you see how it is, right? So glycogen storage disorders, where hepatospleno, it's not hepatorenal. If it is hepatorenal, it's von Gog's. If it is uh, hypoglycemic episodes with increased lactic acid, von Gog's. These things are very important. Here I don't see lactate will all be normal, but the patient has hypoglycemia, and instead of hepatorenal, this is hepatosplenomegaly, and also it has the Pompe's component. That is, you see this hypotonia cardiomyopathy, not the big tongue though, right? So hypotonia cardiomyopathy, hepatosplenomegaly, that's Anderson. Okay, and now coming to McArdle. Now coming to, you should know that McArdle has to only everything to do with the muscles. M, M for McArdle, right? So this occurs only in the muscles, not anywhere else, not in the liver, right? In muscles, there's something called as muscle glycogen phosphorylase. So muscle glycogen phosphorylase, this only converts the glycogen in the muscles to glucose. Now when they're not present, what happens? The muscles are going to suffer, and that is what you will see the patient having myoglobinuria. So it's a different color. So myoglobinuria. What about the heart muscle? Arrhythmia. So there's going to be muscle getting broken down because the muscles are not able to live. So that is why myoglobinuria, arrhythmias of the heart. And there's something called as the second wind phenomena. Now, this is what they usually ask in the questions. That is, just imagine this person with McArdle is running for the first 5 minutes, will feel so fatigued, may get cramps and other issues. They take a break for 5 minutes, and then if they run, they can run. That's because when they're trying to take this break and then they're trying to run, the lipids, okay, during this process, no, the lipids are going to facilitate the muscles to work off. So because the lipids are going to provide energy rather than something to do with the glucose pathway, they will have the second wind phenomena, which means after they get fatigued very quick, they take a break, and after 5 minutes when they run, they can just do the routine exercise. So that's the beauty of McArdle. That's called second wind phenomena. That's because there is an increased muscle blood flow. Remember that there's an increased muscle blood flow, as well as some lipid component also will take place. So that's very important, right? So when muscle blood flow is high, what happens is we see that these patients are not going to have the cramps after taking their 5 minutes of rest. Also very important, remember, is these patients will have normal blood glucose because it has nothing to do with the glucose in the blood. So that is what you have to remember: muscle glycogen phosphorylase. So these are the 5 diseases. And now let's go to the lysosomal storage disorders. So let's start the pathways. So first thing you should know is that this pathway is very important, okay, and it's pretty hard to remember, but the closest way you can remember is something like this. At the heart of the pathway, let's start from the heart. So there is something to do with glucose. That is gluco. Okay, so that is going to be glucocerebrosidase. Okay, glucocerebrosidase. Sorry, glucocerebrosidase. Cerebrosidase will become the enzyme. So glucocerebroside. Okay, so that's going to be there. And glucocerebroside, something to do with cerebrum. You'll hear these topics. There's something called as ceramide. So everything is connected here. Okay, glucocerebrosidase, ceramide. So let's connect the dots, right? Ultimately, it's the ceramide as the heart. So from the right side, we can put as sphingomyelin. Okay, space sphingomyelin, and the left side we have two things. One is cerebroside sulfate, and cerebroside sulfate is going to become galactocerebroside, and galactocerebroside becomes ceramide. Now, when you talk about glucocerebroside, there is something called GM2 that becomes GM3. Doesn't matter if even if you know or not, and it becomes glucocerebroside. Also, to remember is you have something called as ceramide. Okay, ceramide trihexose. Okay, so ceramide trihexose, or you can which is also called as globotriose ceramide. So this is the whole components, and this is very important to remember. So it helps you to remember how the diseases work, right? So now let's put the enzymes. So GM2 to GM3 is the most commonly asked question. So there's something called as hexosamidase, which is also the deficiency of this is going to cause Tay-Sachs. So GM2 to GM3, remember that it's not to glucocereboside, it's GM2 to GM3 hexosamidase. That's the enzyme. And now let's just link the diseases so it'll be easy. So this is Tay-Sachs, Tay-Sachs disease, hexosamidase. How to remember the clinical features? We'll come to that. This is important. Okay, now, yeah, so I forgot to make this connection. Now, ceramide trihexose, right? Now, the ceramide trihexose, or sometimes it's called ceramide trihexose, it is, or whatever it is. The ceramide trihexose should be always remembered separately from the ceramide which is alone. Okay, it's very important. Now, about who's going to break this to glucocereboside? It's going to be broken down by alpha galacto alpha galactose. So it is by alpha galactosidase. Sorry about that. Alpha galactosidase. And who's causing this? What is the disease name? It's called as Febris. Okay, so that's Febris. And so we finished Febris, we finished Tay-Sachs. Now, glucocereboside is going to be converted to ceramide by glucocerebrosidase. And the deficiency of this is called as Gaucher's disease. Okay, now Sphingomyelin is converted by an enzyme called as sphingomyelinase. Okay, so that's it. So this the deficiency is called as Niemann. It's all to bunk. Okay, cerebroside sulfate by an enzyme called as aryl sulfatase. Okay, aryl sulfatase. The deficiency of this is going to cause what? It's going to cause metachromatin leukodystrophy. It's too big, but I'll write it here. It's going to be metachromatin leukodystrophy. Okay, now galactocereboside is getting converted to ceramide, and the deficiency over here is because of galactocerebrosidase. Okay, galactocerebrosidase, and that's because of and this disease is called as Krebs disease. So this is the whole pathway, right? It's very important to remember them. We'll just recite this once. So GM2 to GM3, that is with exosaminidase. The enzyme deficiency is going to cause Tay-Sachs disease. Now let's go here. So glucocereboside to ceramide. This glucocerebrosidase, and that deficiency is going to be Gaucher's. Ceramide trihexose. Okay, also called as globotriosceramide. Okay, as long as, just remember, as long as it's not simple ceramide, it has something to do with that side, that is something to do with Febris, because alpha galactosidase A is going to be absent. Okay, and then we'll talk about this. So sphingomyelin should convert to ceramide. The deficiencies of them is going to be Niemann-Pick disease due to sphingomyelinase deficiency. Cerebroside sulfate should be broken by aryl sulfatase. Okay, and the deficiency of that is metachromatin leukodystrophy. Galactocereboside should convert to ceramide, and but through galactocerebrosidase it should be broken down, and the deficiency of that is Krebs. So simple, right? And just for you to know that, see, any enzyme deficiency is all autosomal recessive, right? With an exception over here. That exception over here is these guys. These guys are going to be X-linked recessive. That's all autosomal recessive. So just remember, Fabry's disease is X-linked recessive. Now let's start with one by one component, right? So let's talk about Fabry. Fabry. Let's start with Fabry. So Fabry, these guys, this guy over here, right? This guy, Fabry. That is ceramide triexose to glucocerebroside. So let's talk about these guys. Now about Fabry's disease, all what you need to know is it is like a triad, right? What's a triad? You should have three things. So one thing is it's going to have hypohidrosis. They're not going to sweat at all in Fabry's. Hypohidrosis. They don't sweat. Okay, dry skins. You will see angiokeratoma, hypohidrosis, angiokeratoma, as well as you will see neuropathy, the two peripheral neuropathy. So peripheral neuropathy is seen in Fabry's disease. So dry skin, you'll see keratomas and you'll see peripheral neuropathy. So that is Fabry's disease. Peripheral neuropathy, angiokeratomas, hypohidrosis. Done. Now what about Krabbe? Krabbe, the interesting part about Krabbe. Okay. Also, not to forget, Fabry is X-linked recessive, right? So just remember that. That's all autosomal recessive. I wouldn't mention. Now Krabbe. Then the beauty of Krabbe. What is Krabbe? Who is causing Krabbe? Let's see that. So these guys, right? Over here. So galactocereboside to ceramide. That is galactocerebrosidase deficiency is going to cause Krabbe. Now Krabbe is something to do with the optic nerve. It's very unique. It's easy to remember because of it. So Krabbe, of course, is crazy. It involves the oligodendrocytes. Okay, it involves the oligodendrocytes. Oligodendrocytes, these cells are seen in central nervous system. So you will see that there's going to be development delay. So decreased intelligence, right? Because of development delay. That's very common with brain stuff. And you will see optic nerve atrophy. You will not see in any diseases optic nerve atrophy except Krabbe's disease. Of course, the same symptom from Fabry's is going to be peripheral neuropathy. They will have peripheral neuropathy. So they'll have all the nerves thing. Peripheral neuropathy, the optic nerve atrophied, and development delay. That's it. So this is Krabbe. Krabbe has everything to do with the CNS, remember, as well as peripheral neuropathy. which is the common thing with Febris. Okay, now let's go to the other diseases. Now, the best way to remember the other symptoms is, see, they will have some less specific symptom, but the key standing out factors, right? So the best way to remember is through this 4 into 4. So here we are going to divide based on the symptoms. So let's just say uh, CNS symptoms. Okay, CNS symptoms, or you can put cherry red as well. So cherry red in the eyes, right? Cherry red spots. So cherry red spots and some CNS symptoms. And over here I'll put about hepatosplenomegaly. So hepatosplenomegaly present, absent, present, CNS present, absent. Okay, and just remember this. Always start from this corner, or however it is, N, G, and T. Okay, and for Niemann Pick, this is for Gaukus, this is for Tay-Sachs. Oh, what are these NT, these new symptoms, right? I'll just put it here for you. So N, that is Niemann Pick. Now Niemann Pick is here. Niemann Pick, sphingomyelinases deficiency. When we talk about Gaukus, oh, where's Gaukus? Glucocerebrosidase. Okay, and where's Tay-Sachs? Oh, I've not seen Tay-Sachs. Oh, okay. So Tay-Sachs are going to be here. Hexosaminidase. So you got it. So these are the three, and these are the symptoms you need to remember. So when we talk about Tay-Sachs and Niemann-Pick, these guys will have CNS symptoms. Okay, apologies for that. So they're going to have CNS symptoms. Yeah. So they're going to have CNS symptoms. But how to differentiate between both of them? Definitely, Niemann-Pick and Tay-Sachs will have cherry red spots. Gaukus, on the other hand, will over here. See, Gaukus over here. So Gaukus will have hepatosplenomegaly. It has nothing to do with nerves because the nerve CNS is negative. Cherry red spot, same goes. Put cherry red spot. Cherry red spots are going to be negative. Okay, so that's Gaukus. So there's nothing to do with CNS and cherry red spots. Tay-Sachs, on the other hand, yeah, definitely cherry red spot, yes. CNS, yes. But when it comes to hepatosplenomegaly, it is a no. So Niemann-Pick has hepatosplenomegaly and the CNS symptoms and cherry red spot. So this is how we will differentiate them. It's going to save a lot of time if you just know this. So just remember how to differentiate them. Okay. You can also, I mean, if you feel this is too big to understand, just remove cherry red. Okay. And just put here CNS slash cherry red. Okay. So one is something to do with eyes and CNS hepatosplenomegaly. Now, if I have symptoms where the question is saying about Tay-Sachs, Niemann-Picks, but they're not talking anything about hepatosplenomegaly, how will I differentiate with the CNS symptoms? It's very simple. Now just remember N, right? That is Niemann-Pick. Niemann-Pick is hyporeflexia. Okay, they'll have reflex low, less than 2. But Tay-Sachs is going to have hyper. That is, they'll have either +3 or +4. +2 is normal, right? So these guys will have +1. So this is how we will differentiate. If someone say hyporeflexia, Niemann. If someone says hyperreflexia, Tay-Sachs. Besides that, this box will do your job. Now, what we have not discussed is hurlers. Hurlers and hunters. Sometime asked. Now, remember, hunter is again X-linked recessive, just like a Fabry. Hurler is autosomal. Usually these two are compared. Okay, so let's see why. So first, what are the enzyme deficiency? Hurler is alpha L iduronidase. Alpha L iduronidase. Hunters is iduronate 2 sulfatase. Okay, that's all. And hunter, remember the name hunter itself. What does hunters do? They're very aggressive. They want to kill animals. So these guys are aggressive. Okay, that's all. When it comes to cornea, these two have difference with cornea. So cornea is clouded in hurlers. Well, cornea is clear in hunters because for hunting you need clear corneas. So that's how you differentiate both hunters and hurlers. Because hunter, the cornea should be clear. They are really good at hunting, so they should be aggressive. And iduronate 2 sulfatase, just like aryl sulfatase for metachromatic leukodystrophy, where I didn't discuss because there's nothing much they would ask you besides what is the enzyme which is involved in metachromatic leukodystrophy. Other than nobody will ask you anything. But iduronate 2 sulfatase hunters. Hurlers, they'll have cornea clouding, but both of them will have one symptom that you should always remember. This symptom should strike you whether it has something to do with hurlers or hunters, and that is these two guys are going to have airway obstruction. These guys are very prone for airway obstruction, and from the time they're infants, they'll have a lot of airway obstruction issues. Okay, so that is all you need to remember. Now, when you have to remember about Gaukas, as if we didn't speak much about Gaukas, right? So it's all like your HPO channel. That's Gaukas. So that is either hepatosplenomegaly. You're going to have bone issues. Now, what are the bone issues? You're going to have osteoporosis, or you're going to have avascular necrosis of the hip, avascular necrosis of the hip, femur bone, right? And so that is about bone. And yeah, as I mentioned, osteoporosis, or you can think B as blood as well, and they're going to have pancytopenia. So it's how you can mix up your blood. Some of them keep O as O positive thing, pancytopenia. I've seen few people B for blood, B for bone. So it's how you make it. Just remember H for hepatosplenomegaly, which your this plus minus box over here will help out. But besides that, pancytopenia and bone issues are seen in Gaukus. So that is something to remember. So besides that, you have your hurlers, hunters, and you got it. Both of them are going to have airway issues. And they don't ask this, but the last important one is mucolipidosis. Mucolipidosis 2, which is also called as the ICEL disease. Now the beauty of ICEL disease, again, autosomal recessive, okay? And who is involved over here is NAG. What is that enzyme? This enzyme is N-acetyl glucose 1 phosphotransferase. We don't have to remember it all, you just remember it's NAG. NAG. Okay, so glucose 1. So it is glucose 1 phosphotransferase. So remember that, phosphotransferase. Now, about ICEL disease, what you should know is that ICEL disease can have cornea clouded. So it could be one of the differentials for hurlers, right? Hurler has cornea clouded. Oh, so does ICEL. And besides that, this is a lysosomal issue. So remember, the process is something to do with lysosomes. They will have bad oral hygiene because they'll have gingival hyperplasia. And that's changing the morphology of their mouth. So that can cause organisms to live in a different way. So that is gingival hyperplasia. Okay, so corneal clouding, gingival hyperplasia. This is something to be remembered. And sometimes there'll be something like there's an inclusion bodies in the lysosome. So this would be the keyword they would provide: inclusion bodies in the lysosomes. And they could even have coarse face. Okay, coarse face. Coarse face can mean anything. Just Google and see all the spectrum of coarse faces. Okay, so that's coarse face. So ICEL disease, cornea clouding. So any cornea clouding, don't think it's hurlers. It can be ICEL disease. If it has something to do with lysosome ICEL disease, they'll have gingival hyperplasia and coarse face. So if some troublesome face, uh, gums messed up, ICEL disease, that's the way to go. So by now we have discussed the lysosomal storage disorders and glycogen storage disorders. Now the most important thing is for you to save this video for the end of your day, a day before your exam, or on the day when you're traveling towards your exam hall. This is what you need to see. So try to revise this a week before and do this on the day of exam, and you're good to go. So all the best, and thank you for everything.